40%. So she said that in 7 days there is a 40% improvement. Now you have to ask me why they are improving. जब आप कह रहे हो कि lung fibrosis इतना extensive है, pulmonary hypertension इतना severe है, तो why there is an improvement? So what is that meaning? Why she is improving? Is it because steroids are working? Number one. Is it because we are giving her oxygenation? Is it because that she is getting an attention of it? We don't know. So how to know about it? That's why I'm telling you. Now let's discuss about. That's why I tell you that we will go by the case. The best way to learn pulmonology is a case. Now what happened? Initially we thought she's a COPD because she presented with a type 2 failure. She had a little crackles, little V's and all those things. Still the V's component is there. When CT was done, the picture came because I was really wondering why she has such a severe pulmonary artery hypertension. You mentioned that it gone up to 50, 60, hai
70.
Now when we saw this X-ray, and again I auscultated, I said, look, there's a difference is that the type of adventitious sounds which you hear in chest, that is the differentiator. Now what happens? If the lung is shrinking, now what happens is lung fibrosis, interstitium goes into a shrinkage. So when there is an interstitial shrinkage, so it is called Velcro rails. Velcro means जैसे वो चिपकता है ना, कच 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 Velcro rails. So whenever you see an ILD patient, you appreciate a Velcro rails. Now where we went wrong? How will you differentiate in COPD rails from Velcro rails? Can anybody guess it? How will you differentiate a COPD rails from an interstitial lung disease rails?
Sir, the rails are fine and they don't change with cough.
Yes, you know. आप जोर से खांसिए और खांसिए जोर से there is no change in the quality of cough because COPD by definition is a small airway disease. There you will have secretions and the quality of it. Sometimes you get biphasic rails, sometimes you get, sometimes rails are so deceptive. So when you find leathery rails, Velcro rails, not changing with cough, this is the first thing. Now still there may be a confusion. Still आपको लग सकता है कि यार नहीं हो रहा है. The second thing what you do is called tracheal auscultation. You know what is tracheal auscultation? आराम से मुंह खोल के सांस लो. Just see. सांस लो. Take a deep breath. There is no wheeze.
Yes, sir. No wheeze.
In COPD, invariably you will get a wheeze on the trachea because it's an airway disease. Will you do that?
Yes, sir.
So what you learn, one is that changing in the cough, as you rightly said. Second is that ausculted trachea. So that clearly, because interstitial is a distal disease, it's an interstitium of the lung disease. तो उसमें कभी भी tracheal secretions या wheeze नहीं आएगा. The second thing. Third thing, this is called band size. Now what happens? You will put your fingers like this on both the chest. Ask the patient to little bend. Okay. Now whenever there is a shrinking of the lung, when you feel another shrinking, what will you get? The lungs band size will be less. Yes. Now what is band size? How we clinically monitor? Suppose the patient has come to you first time in your OPD. आप देखो how many fingers of. Now if you see, in a COPD, you will get little large lung, you will get little hyper-resonant notes, here you will get an impaired note because it's a restrictive lung, shrinkage lung. And secondly, you will find narrowing of intercostal space. You feel the space, it's narrow. You feel the space, it's narrow. है ना?
Yes, sir. There is crowding of ribs.
So crowding of ribs कब होगा? When there is a volume loss. So whenever you find a volume loss, impaired note, not changing with the cough, and there is no tracheal wheeze, it is interstitial. So you have learned good things.
Yes, sir.
Then another clinical observation. Clubbing is an hallmark of interstitial lung disease. COPD clubbing doesn't happen. She has clubbing. Grade 2 clubbing. You see?
Yes, sir. Parrot weak.
You understand?
Yes, sir.
So will you repeat what are the 5 things you will differentiate from COPD? Number 1.
Number 1 is crackles that don't change on coughing.
Number 2.
Second is wheeze, tracheal auscultation. There is wheeze. There is no wheeze present in this thing, ILD, but we will be present in COPD. Third thing is there will be shrinkage of the lungs.
Absolutely. Feel the intercostal space.
The intercostal space will be narrow. There will be crowding of the ribs, and there will be in
Invaders.
COPD there will be hyperresonant
It will
sound,
be impaired. Wonderful.
and in this will be impaired. On
What else? And the last?
percussion. And the last thing is that there will be clubbing.
Clubbing. So you can start with the other way, because start with the clubbing, because that is general physical exam.
Yes.
Okay. Another very important thing in which I want to tell you is that make the patient lie down. थोड़ा लेट जाइए. See the P2 area. यहाँ because of shrinkage in COPD sometimes P2 you cannot appreciate because it's an hyperresonant. Here you will find P2 loud. You see? लंबे सांस लो. होल्ड करो. You see how significantly it is loud?
Yes, sir. Yes, sir.
It's a loud P2, a split P2.
Yes, sir.
This is a hallmark. You will not get this kind of P2 loud even if there is a pulmonary artery hypertension in COPD, because they have hyperlucent lungs. Anteroposterior diameter increases. So will you learn this?
Yes, sir.
So this is a learning. Now, second thing which I'm asking.
इस साइड से सांस नहीं ले
ठीक है, वो सब ठीक हो जाएगा. Now the second thing is that coming to this, so now we are very sure CT shows there's a volume loss, there's interstitial changes. Even in interstitial lung disease, there could be COPD changes. Why? Because whenever the interstitial goes into shrinkage, the rest of the lung goes into compensation. So you may appreciate a wheeze. You may get at places there are. That's why I say now in CT, if you see here, there are places which are hyperlucent. You see?
Yes, sir.
So what happens whenever there is a shrinkage? There may be an hyperlucency also, but typical
Compensatory.
here you find a typical what you call those honeycombing or a bottle appearance. You know that split bottle appearance. एक bottle को तोड़ देते हैं ना, glass तोड़ने वाला appearance. You understand? Typical honeycombing you are getting in. All जैसे interstitial network पूरा thickened पड़ा हुआ है, आप देख रहे हो? Very symmetrical. But at places you are getting some emphysematous changes. These are all compensations. कंपेंसेटरी एम्फाइसीमा तो होगा ही ना. लंग श्रिंक करेगा, कैसे काम करेगा लंग्स के अंदर? सो यू हैव लर्नड दैट दिस इज एन इंटरेस्ट. नाउ व्हाई इट इज यूएपी? नो, इट मे नॉट बी यूएपी. It may be drug induced. She has been consuming some homeopathy drugs. So first thing is that let us get that homeopathy drug and send it for assay.
Okay.
There is an address I'll give you, Central Drug Research in Lucknow. They give it in 7 days. So let assay that out. Is it a drug induced or not? Now coming to your academics, whenever we talk of interstitial lung disease, either it is idiopathic or secondary. Secondary is very negligible. So secondary, whenever you have to rule out autoimmune disease. So basic parameters, workout parameters is that get an autoimmune done. ANA, scleroderma, CNCA, PNCA, though we have not done it, but normally what I do RA factor, I do normally anti-nuclear antibody, I do SCL70, anti-double stranded DNA, you can do CNCA and PNCA also, so autoimmune. Second thing is look out drug induced. Third is that occupational. What are the occupational? Pigeons, which is called HSP. Hypersensitive pneumonitis could be. Then could be bagasosis, which is bagasosis could be from sugarcane. Then bicinosis, which can be cotton wool workers. She has been working in some cotton wool areas also for years. You know, if you ask her, वो बनाती थी कुछ. She has an history of cotton. आप रेशे का काम करते थे ना, रुई का?
हाँ,
रुई बुनते थे ना?
हाँ
क्या
जी।
काम करते थे बताइए?
स्वेटर बनाते थे।
स्वेटर बनाते थे. स्वेटर का रेशा उड़ता था?
नहीं नहीं, वो दूसरी नॉर्मल ऊन।
क्या बहुत सारे स्वेटर बनाते थे?
हाँ, घर में बनाती थी थोड़े।
थोड़ी बना के बेचते भी थे इसको.
बेचती भी थी।
स्वेटर का रेशा उड़ता था जब आप
नहीं वो
ऊन का रेशा? You never know. Sometimes this cotton wool they
दूसरे ऊन आती
can
है
call
ना।
hypersensitivity pneumonitis.
वो
You never
गरम
know ना.
वाली ऊन का नहीं है, दूसरी
ठीक है,
ऊन
तो ये भी
वाली।
देखो. Then you come drug induced. तो एक चीज आपको करना पड़ेगा. If all she has an occupation, get an, which we have missed it, get an IG level done also. Because we have to see whether she is allergic or non-allergic interstitial lung fibrosis. If she is allergic, why I'm asking you, why she is saying I'm 40%? Allergic will respond very well to steroids. इसलिए उनको एक सैंपल दे दो. नाउ शी इज गेटिंग डिस्चार्ज टुमारो, वी आर प्लानिंग टू डिस्चार्ज हर. उनको बोलिए सैंपल डॉक्टर साहब के सेंटर में दे दो, एक आईजी लेवल भी कर लेंगे. because very important. And P anchor C anchor भी करवा लेंगे इसमें, ठीक है, because we'll get the report tomorrow.
जी सर.
So that means now coming to the home protocol, long-term oxygenation, pulmonary artery hypertension lowering drugs, pyrfenidone or nintedanib, whatever the drug we want to give it, short course of oral steroids will give it, and some inhalers to reduce the compensatory emphysema stages like Foracort or something, bronchodilator and ICS, and rehabilitation. She is an ideal case for pulmonary rehabilitation, which is a component of nutrition, breathing exercise, motivation, peripheral muscular rehabilitation, all those things. So we put her into home rehabilitation program. That's all. Okay? Anything you want to ask? Okay? So this is called bedside learning. You like it? Okay.
Thank you sir.
Hmm.